Welcome to the Deep Dive. Today we're going right to the heart of a cornerstone of modern medicine, local anesthetics. We're aiming for real mastery here, moving beyond just knowing they block pain. We want to understand them from the atoms up.
Exactly. Our goal isn't just the basics. It's about getting that elite level grasp, how these molecules are built, how they interact with our nerves right down at the ion channel level.
And then how that knowledge translates into the really sophisticated ways clinicians use them every day.
Right, from basic chemistry to advanced practice.
Okay, so first things first. Let's define our terms. What exactly is a local anesthetic in LA, and how is it fundamentally different from general anesthesia?
Well, at its core, a local anesthetic is a drug designed to cause a reversible loss of sensation, especially pain. And crucially, it does this only in a restricted area of the body.
Reversible and restricted. Keywords.
Absolutely key. The mechanism is, well, conceptually simple but pharmacologically quite elegant. They block nerve impulses, both generation and conduction, right where they're applied. And importantly, they do this without causing any lasting damage to the nerve structure itself.
Okay, now let's contrast that with general anesthesia, or GA. The source material draws a really clear line here, using table 26.1. It feels like a totally different philosophy.
It absolutely is. The biggest difference, site of action. GA works centrally on the brain. It causes a global depression, loss of consciousness.
Whereas LAs are strictly peripheral players.
Exactly. They work on peripheral nerves, nerve roots, nerve endings. Consciousness remains completely untouched. Your patient is awake, potentially even cooperative.
And that difference in sight leads directly to this idea of physiological trespass, right?
Precisely. Physiological trespass is basically how much you're disrupting the body's normal functions. GA involves high trespass. You're taking over. You have to manage breathing, circulation, temperature sometimes. It's a major intervention.
Which makes it riskier for certain patients.
Definitely. If someone's already got significant heart or lung problems, putting them through GA adds a layer of risk. LAs, on the other hand, have very low physiological trespass. They're generally much safer for those vulnerable patients because you're not shutting down the whole system.
So for minor procedures, dental work, things like that, LAs are the go-to if possible.
Always preferred, less risk, faster recovery, patient can often participate. But, for major complex surgeries, GA is still absolutely essential. There's no substitute when you need that level of control and unconsciousness.
Okay, let's unpack this then. We need to understand how these molecules actually do their job. Before we even get to the nerve itself, we need to look at the drug structure. The chemistry is the foundation.
It really is. Everything flows from the chemical design. The fundamental property that makes LAs work is that they're weak bases, and crucially, they are amphiphilic.
Amphiphilic, right? That means they like both water and fat environments, like a chemical double agent.
Exactly like that. It's essential because they have to navigate both the watery environment of your tissues and plasma and the fatty environment of the nerve cell membrane.
So what are the parts of this molecule?
There are three key components. First, you've got the lipophilic part, usually an aromatic residue, like a benzene ring. That's the fat-loving end, lets it sneak through membranes.
Okay.
Second, there's the hydrophilic end, typically a secondary or tertiary amine. That's the water-loving part, makes it soluble in body fluids.
Got it. Lipophilic head, hydrophilic tail.
Sort of, yeah. And connecting them is the third part, an intermediate alkyl chain. Now, the nature of the link in that chain is incredibly important. It divides LAs into two major chemical families.
The ester versus amide distinction. This seems critical.
It's fundamental to their behavior in the body. First, you have the ester-linked LAs. Think of the older ones. Cocaine, procaine, tetracaine. They have an ester bond connecting the chain to the aromatic part.
And that ester bond dictates how they're broken down.
Entirely. Esters are rapidly hydrolyzed, broken apart by an enzyme floating around in your blood plasma called pseudocholinesterase. It's a very fast process.
Which means?
Short duration of action. The effect doesn't last long, and generally the block isn't as intense. But the real clinical issue with esters historically has been the higher risk of allergic reactions.
Why is that?
Well, often the breakdown product is something called para-aminobenzoic acid, or PABA, and PABA is known to trigger immune responses in some people. Plus, they often needed preservatives like methylparaben, another potential allergen.
So esters are mostly historical footnotes now, maybe some topical uses.
Pretty much. Very rarely used for injections like nerve blocks today. Now, contrast that with the modern workhorses, the amide-linked LAs, lidocaine, bupivacaine, ropivacaine. These are the big ones.
And they have an amide bond instead.
Right. And that amide bond is much tougher. It's not touched by plasma enzymes. Amides can only be broken down in the liver by specific microsomal enzymes, the cytochrome P450 system.
A much slower, more controlled breakdown process.
Much slower, and it depends heavily on liver function and blood flow to the liver. This means amides give you a much more intense, much longer-lasting anesthetic effect.
And fewer allergies.
Far fewer. True hypersensitivity to amides is really rare. It's a huge safety advantage. One other point. Amides tend to bind significantly to a plasma protein called alpha-1 acid glycoprotein.
How does that affect things?
It influences how much free drug is actually available to act on the nerves. So conditions that change protein levels can affect how the drug behaves. It adds another layer to consider when dosing.
Okay, structure sorted.
Yeah.
Now, the main event, how do they actually block the nerve signal? It's all about the sodium channel, right?
Absolutely. The ultimate effect is stopping the nerve impulse. They do this by blocking the influx of sodium ions plus dollars that normally rushes into the nerve cell during the start of an action potential.
That initial spike of electrical activity.
Exactly, the depolarization phase. If you block enough sodium channels along a critical length of the axon, the nerve impulse just fizzles out. It can't propagate. Conduction fails.
Right. But here's where it gets clever. That sort of chemical paradox. The drug needs to be two things at once.
The lipophilicity ionization paradox,
Yeah.
yes. LAs are weak bases. In the body's fluids, they exist in an equilibrium between two forms. The unionized base form, let's call it TextBDA, and the ionized cationic form, TextBH+.
TextB and TextBH. Both are needed, but for different jobs.
Precisely. Potency, how strong the block is, correlates with the lipid solubility of the unionized base. This form is neutral. It's fatty. It needs to be in this form to slip through the lipid-rich nerve membrane, the axolemma. Think of it as the key to get through the door.
So TextB gets it inside the nerve cell.
Yes. But once inside the axon, where the internal environment, the exoplasm, is slightly more acidic, the equilibrium shifts. The drug picks up a proton and becomes the ionized, the GalGH, TextBH plus DA.
And this charged form is the one that actually does the blocking.
This is the active species. The TextBH plus form is what physically binds to the receptor site inside the sodium channel pore and blocks sodium passage. If it remained uncharged inside, it wouldn't bind effectively.
So the speed at which the anesthetic starts working must depend on this chemical balancing act.
Directly. It's governed by the drug's text pay. Remember, TextPay is the text plus that TextBH is Oricace is ionized plus, and 50% is unionized. Body text is around 7.4.
Right.
Drugs with a low text peaks, like lidocaine, around 7.6 to 7.8, are already pretty close to body text pH. So at 7.4, a decent chunk, maybe 30–40%, is already in the unionized form.
Ready to cross the membrane quickly.
Exactly, which means a fast onset of action.
What about drugs with a higher PK, like bupivacaine?
Bupivacaine's text pay is higher, maybe 8.1 to 8.9. That's further away from 7.4. So at physiological text pay, much less of it, perhaps only 15% or even less, is in that crucial unionized form needed for penetration.
Meaning it takes longer to get enough drug inside the nerve.
Leading to a slower onset of anesthesia. Though it's worth noting chloroprocaine is a bit of an outlier, high PK but still fast onset, likely due to the large dose typically used and rapid diffusion.
Fascinating. Okay, let's really zoom in now, right down to the sodium channel itself. This isn't just a simple hole in the membrane.
Oh, not at all. It's a sophisticated piece of molecular machinery. A large glycoprotein, about 300 kilodaltons. The main part is the alpha subunit, which actually forms the pore.
And it has gates.
It has gates that control the flow of sodium ions. Think of an activation gate, the in gate near the outside, and an inactivation gate, the act gate on the inside near the cytoplasm.
How do they work?
At rest, the channel's closed. When the nerve membrane gets stimulated and reaches its threshold potential, the in gate flicks open really fast. That's the activated or open state sodium rushes in. Almost immediately after opening, the H gate swings shut, plugging the channel from the inside. That's the inactivated state. No more sodium can get through, even if the M gate is still open. The channel stays inactivated until the membrane repolarizes back to its resting potential, allowing the gates to reset.
Resting, activated, inactivated. Those are the three states. Where does the LA molecule actually bind?
The LA binding site is located inside the channel pore, nearer the cytoplasmic side. It's mainly formed by a specific part of the alpha subunit called the S6 segment of domain Hebe.
So the drug has to get inside the cell first, then find its target within the channel pore.
Correct. The unionized form crosses the membrane, reionizes to TextBX plus inside, and then accesses its binding site from the intracellular side.
And this leads to a really important clinical concept, frequency dependence. What's that about?
Frequency dependence, or use dependence, means the block works better on nerves that are firing rapidly. The LA molecule has a much higher affinity. It binds much more strongly to the channel when it's in the activated open state or the inactivated state compared to the resting state.
So a busy nerve essentially makes itself more vulnerable.
Precisely. Every time the nerve fires, its sodium channels cycle through the open and inactivated states. This gives the ionized LA molecule plus more opportunities to bind. Once bound, it tends to stabilize the channel in that inactivated state, making it take longer to recover and become ready to fire again. It prolongs the refractory period.
So a nerve that's just sitting there, quiet.
Is relatively resistant to the block.
Yeah.
But a pain fiber that's firing intensely, sending lots of signals, it's constantly opening and inactivating its channels, practically inviting the LA to come in and shut it down. That's why LAs are so good at targeting active pain signals.
Okay, so we've got the molecular mechanism. But LAs don't just block the main nerve trunk, do they? They act more broadly at the site.
That's right. Locally, they can block sensory nerve endings right in the tissue. The main nerve trunks, connections at ganglia, even the neuromuscular junction where nerves talk to muscles. They can also reduce acetylcholine release from motor nerves.
So the effect on a mixed nerve is both stopping sensation and potentially causing muscle weakness or paralysis in that area.
Yes, but as we touched on with frequency dependence, not all nerve fibers are created equal in terms of sensitivity. This brings us to differential sensitivity.
Right. Some fibers get blocked more easily than others. It depends on size and myelination.
Size and myelination are key factors. Generally, smaller diameter fibers are more sensitive than larger ones. And for fibers of the same diameter, myelinated ones tend to get blocked before unmyelinated ones.
Why is that? Is it just size?
It's a bit more complex. It relates to the critical length of axon that needs to be blocked for the signal to fail. For myelinated nerves, you need to block the signal at several consecutive nodes of Ranvier, those gaps in the myelin sheath. Smaller myelinated fibers have shorter distances between their nodes, so the LA doesn't have to spread as far physically to block the required number of nodes. Also, smaller sensory fibers often fire at higher frequencies and for longer durations.
Making them more susceptible due to that frequency dependence we just talked about.
Exactly. It all ties together. The physiology of the small pain fibers makes them intrinsically more vulnerable to LA action.
And this difference in sensitivity leads to a predictable order in which functions are lost.
A very predictable order of blockade. Autonomic functions like control of blood vessel diameter go first, as those fibers are often small and unmyelinated or lightly myelinated.
Then sensory.
Yes. Within somatic sensation, the sequence is usually: first, pain perception is lost. Then, the sense of temperature, followed by touch. And finally, the sense of deep pressure. Motor function, carried by the largest fibers, is typically the last to go.
That matches clinical experience. You feel numb before you feel weak. What about taste? You mentioned that sequence too.
Yes, quite specific. Bitter taste is apparently the most sensitive, lost first, then sweet and sour. Salty taste is the most resistant. It just highlights again that different sensory modalities use fibers with different properties.
And recovery happens in the reverse order.
Generally, yes. The functions lost first are the last to come back as the anesthetic wears off.
Now, thinking about injecting near a large nerve, like in the arm for surgery, does it matter where in the nerve trunk the fibers are?
It absolutely does. Nerves aren't just uniform bundles, they have structure. They're wrapped in protective sheaths, like the epineurium, which can slow down diffusion of the LA.
So the drug doesn't reach all fibers at the same time?
Correct. Fibers located in the outer layers, the mantle of the nerve bundle, get exposed to the LA first and are blocked sooner. Fibers deep in the core of the nerve take longer to be reached.
And does that mantle core arrangement relate to the body parts they supply?
Often, yes. Axons supplying more proximal parts of a limb closer to the body tend to be located in the outer mantle, so the shoulder might get numb before the fingers in a brachial plexus block. Axons for distal areas are often deeper in the core. Also, motor fibers are frequently found around the circumference, making them susceptible relatively early.
Okay, let's switch gears to a common problem. Trying to numb up an area that's already inflamed or infected, like a dental abscess. Why do LAs often fail in that situation?
Ah, yes, the inflamed tissue challenge. There are really 4 main reasons why LAs work poorly there. The most critical is the change in tissue pH.
Inflammation makes the tissue acidic, right?
Exactly. The local pH drops. Remember, our weak base La needs to be in the unionized form to cross the nerve membrane. In an acidic environment, the equilibrium shifts dramatically towards the ionized form, plus disty areas.
So the drug gets trapped outside the nerve. It can't penetrate.
Precisely. Much less drug gets inside to the receptor site. That's reason number one. Reason two, inflammation causes vasodilation, increased blood flow.
Which washes the anesthetic away faster.
Washes it away very quickly, reducing the concentration and duration of contact with the nerve. Third, if you're using adrenaline as a vasoconstrictor with your LA,
Which we'll get to.
its effectiveness is reduced in acidic conditions. And fourth, the inflammatory process itself releases substances, mediators, that might actually counteract the LA's effect on the sodium channel. It's a perfect storm for block failure.
That makes sense. So let's talk about deliberately adding vasoconstrictors, usually adrenaline, to the LA solution. Why is that done so routinely?
It's done for three very important reasons, all stemming from the local vasoconstriction adrenaline causes. First, by clamping down local blood vessels, it dramatically slows down the rate at which the LA is absorbed away from the injection site into the systemic circulation.
Keeping the drug where you want it for longer.
Exactly. This prolongs the duration of the anesthetic block, sometimes doubling it or more. Second, because the drug stays concentrated locally for longer, it often enhances the intensity or depth of the block.
And the third reason sounds like a safety benefit.
A major one. By slowing absorption, it reduces the peak concentration of the LA that reaches the bloodstream. This significantly lowers the risk of systemic toxicity affecting the brain or heart.
But adding a potent drug like adrenaline isn't without its own risks, is it?
No, definitely not. There are two main concerns. Locally, the reduced blood flow, especially if prolonged, can impair tissue oxygenation. This might lead to more swelling, delayed healing, or in rare, severe cases, even tissue necrosis, particularly if the injection is too concentrated or in a vulnerable area.
And systemically.
Systemically, some of the adrenaline inevitably gets absorbed too. In susceptible individuals, this can cause a rise in blood pressure, palpitations, or even trigger arrhythmias, especially in patients with heart conditions or on certain medications.
Which brings us to a critical safety rule, an absolute do not.
The cardinal rule. Never use vasoconstrictors for nerve blocks in areas supplied by end arteries. This means no adrenaline-containing solutions for ring blocks of fingers or toes or injections into the hand, foot, the tip of the nose, the pinna of the ear, or the penis.
Why not?
These areas rely on very specific arteries for their blood supply, without much backup or collateral circulation. If you constrict those vital arteries with adrenaline, you risk cutting off the blood supply completely, leading to ischemia and potentially catastrophic tissue loss, like gangrene. It's just not worth the risk.
So even though LAs are meant to work locally, they eventually get absorbed. And it's that absorption and what happens next, the pharmacokinetics, that determines the risk of systemic problems.
Absolutely. Once the LA gets into the bloodstream, its effects elsewhere in the body and its potential toxicity depend entirely on how high its concentration gets in the plasma and how quickly the body eliminates it.
And the absorption rate varies a lot depending on where you inject.
Hugely. Injecting into a really vascular area, like between the ribs for an intercostal block, leads to very rapid absorption and high blood levels quickly. Injecting somewhere less vascular, like around the sciatic nerve, which is bundled in more connective tissue, results in slower absorption.
Once absorbed, where does it go?
LAs are quite lipophilic, fat-loving, so they distribute rapidly into tissues with high blood flow. That means the brain, heart, liver, kidneys see high concentrations relatively quickly after absorption.
And how the body gets rid of them brings us back to that crucial ester versus amide difference.
Yes, it's central to their safety profiles. Ester LAs, like procaine, are rapidly chewed up by that pseudocholinesterase enzyme right in the plasma. Their lifespan in the body is very short.
But amide LAs,
Amides, like lidocaine or bupivacaine, are stable in the plasma. They have to be transported to the liver to be metabolized by the P450 enzyme system. This is a much slower process.
and if the liver isn't working well.
Then the metabolism slows down significantly. This is critically important. For any patient with liver disease, cirrhosis, significantly reduced hepatic blood flow, perhaps due to heart failure, or even just the elderly who naturally have reduced liver function.
A maximum safe dose of an amide LA has to be reduced.
Significantly reduced, because the drug will hang around for much longer, reaching potentially toxic levels with doses that would be safe in a healthy person.
Okay, let's talk about those toxic effects. The central nervous system seems particularly sensitive.
The CNS is usually the first system to show signs of toxicity. Now, the interesting thing is, although the fundamental action of LAs on neurons is inhibition.
The initial symptoms often look like stimulation, excitement, twitching.
Exactly. It seems paradoxical, but it's because the LAs initially inhibit the inhibitory pathways in the brain more readily than the excitatory pathways. By taking the brakes off, you get a temporary period of apparent stimulation.
Like restlessness, maybe some euphoria, tremors.
Yes, those are early signs. Before the LA concentration rises high enough to cause generalized inhibition of all neurons, leading to drowsiness, unconsciousness, and eventually respiratory depression.
Cocaine is the extreme example of this stimulant phase, isn't it?
It's the classic, though obviously complicated by its other actions. But the sequence is textbook. Euphoria, excitement, agitation, maybe muscle twitches, escalating to full-blown convulsions, followed by coma, respiratory failure, and potentially death if untreated.
For the synthetic LAs we use routinely, what are the really critical early warning signs a clinician needs to watch for during an injection? Signs that say, stop injecting N-double.
The very first signs are often subtle sensory changes. Numbness or tingling around the mouth, we call it circumoral numbness, a metallic taste, dizziness or lightheadedness, tinnitus, ringing in the ears, maybe blurred vision or difficulty focusing.
Those are the canaries in the coal mine.
Absolutely. If the patient reports any of those, you stop, because the next stage, if more drug gets in, is increasing CNS excitation. Restlessness, agitation, slurred speech, shivering, muscle twitching, which can then progress rapidly to generalized seizures or convulsions. And after the seizure phase comes unconsciousness and coma.
How do you manage the seizures if they happen?
Airway, breathing, circulation first, always. But specifically for the seizures, the treatment is an intravenous benzodiazepine, usually diazepam or midazolam. They work quickly to suppress the excessive CNS activity and stop the convulsions, preventing further harm like hypoxia.
Okay, CNS covered. What about the heart, the cardiovascular system?
The CVS is generally less sensitive than the CNS, meaning you usually need higher blood concentrations to see significant cardiac effects, maybe 2 to 3 times the level that causes seizures.
And the effects are generally depressant.
Yes, LAs act like class I antiarrhythmic drugs. They depress the heart's electrical activity, reducing automaticity, the pacemaker rate, excitability, and conduction velocity. They also decrease the force of contractility, and prolong the heart's electrical recovery time, the effective refractory period, or ERP.
But again, there's a huge difference between different LAs here, especially lidocaine versus bupivacaine.
A night and day difference, and absolutely critical knowledge. Bupivacaine is notoriously cardiotoxic.
Why bupivacaine specifically?
It's highly lipid-soluble and binds very tightly to the cardiac sodium channels, especially during the inactive state, and then dissociates very slowly. This slow-off binding means it causes profound and prolonged blockade of cardiac conduction.
Leading to what kind of problems?
Severe conduction blocks, a prolonged QTC interval on the ECG, and a high propensity to trigger life-threatening ventricular arrhythmias like ventricular tachycardia or fibrillation, which can rapidly lead to cardiac arrest.
And bupivacaine-induced cardiac arrest is particularly difficult to treat, right?
Extremely difficult. Standard resuscitation often fails because the drug is so tightly bound. This is why the discovery of lipid emulsion therapy was such a breakthrough.
How does that work? Giving fat intravenously?
Essentially, yes. Infusing a 20% lipid emulsion acts like a lipid sink in the plasma. Because bupivacaine is so lipophilic, it prefers to partition into the lipid phase, effectively pulling it out of the cardiac tissue and away from the sodium channels, allowing the heart to recover. It's a specific antidote for severe bupivacaine toxicity.
Now, compare that nightmare scenario with lidocaine.
Lidocaine is much, much safer from a cardiac perspective. At therapeutic doses, it has minimal effect on contractility or conduction speed. In fact, it actually shortens the ERP slightly. It has very low proarrhythmic potential.
So low that we actually use it as an antiarrhythmic drug.
Yeah, exactly. Intravenous lidocaine is a standard treatment for ventricular arrhythmias, a class 1B antiarrhythmic. The difference in cardiac safety between lidocaine and bupivacaine is vast.
Okay, summarizing other adverse effects. Hypersensitivity.
Much more common with the older ester LAs, often due to PHARMACOLOGY or preservatives. Very rare with amides. True amide allergy is almost unheard of, though patients might report side effects they mistake for allergy.
And the absolute must-do procedural safety check.
Always aspirate before injecting any significant volume of LA. Pull back gently on the syringe plunger to make sure no blood appears. This confirms you're not inside a blood vessel, preventing an accidental intravenous bolus which could cause immediate severe toxicity.
Any important drug interactions to keep in mind?
Yes, particularly with the amide-LAs. Beta blockers, like propranolol, can reduce liver blood flow. Since amides rely on liver blood flow for metabolism, beta blockers can slow their clearance, potentially increasing the risk of toxicity.
Good point. And we have to mention cocaine's unique extra effect.
Right. Beyond its LA action, cocaine also blocks the reuptake of norepinephrine and adrenaline at nerve terminals. This sympathomimetic effect causes local vasoconstriction, unlike most other LAs which cause vasodilation, but also systemic effects like tachycardia, hypertension, and contributes to its cardiac risks and abuse potential.
All right, let's look at some of the individual players now. The specific LA drugs and their particular roles or niches. Starting with the original, cocaine.
Cocaine, the alkaloid from the erythroxylon coca plant. Historically vital, the first LA used clinically back in 1884, mainly for eye surgery.
But its unique properties make it problematic today.
Very. It's a powerful CNS stimulant, highly addictive, leading to psychological dependence, and it has that unique sympathomimetic action causing vasoconstriction. Clinically, that vasoconstriction can actually be too intense, sometimes leading to tissue damage, especially corneal sloughing if used in the eye.
So its use is very limited now.
Extremely limited, maybe occasionally topically in nasal surgery where its vasoconstriction helps control bleeding, but generally avoided due to toxicity and abuse potential.
Okay, onto the real workhorse, lidocaine.
Lidocaine, or lignocaine, is probably the most versatile and widely used LA worldwide. It hits the sweet spot. Relatively fast onset, about 3 minutes.
Because of that favorable PK near physiological pH.
Exactly, and it has a moderate duration suitable for many procedures. You can use it topically for infiltration, nerve blocks, epidurals, spinals, intravenous regional anesthesia, Beer's block. It does almost everything.
Plus its role as an antiarrhythmic. Very versatile.
The jack of all trades and master of many.
Then we have bupivacaine, the long-acting one.
Bupivacaine is known for its potency and long duration, lasting maybe 6, 8, even 12 hours, depending on the concentration in sight. It's much more lipophilic and protein-bound than lidocaine.
And its key clinical advantage is that ability to separate sensory block from motor block at lower doses.
That's its standout feature differential blockade. At higher concentrations, it blocks everything. But if you use a dilute solution, say 0.25% or even 0.125%, its high lipid solubility lets it effectively block the smaller, more sensitive pain fibers, A delta and C fibers,
while having less effect on the larger, thicker motor fibers.
the LIFA.
Exactly. This allows for excellent pain relief without significant muscle weakness or paralysis.
Which is perfect for?
Two main areas shine. Obstetric analgesia, providing pain relief during labor while allowing the mother to still push effectively. And post-operative pain management, often via continuous epidural infusion, allowing patients to get up and move around much earlier, which speeds recovery.
But always shadowed by that cardiotoxicity risk we discussed.
Always. The high potency and long duration come at the price of cardiac risk if significant systemic absorption occurs.
Which naturally leads us to ropivacaine, developed specifically to be safer.
Ropivacaine is a slightly newer drug, structurally related to bupivacaine. It's the pure S-enantiomer. It was designed to offer a similar long duration of action, but with a better safety profile, particularly regarding the heart.
And it achieves this by being less fatty.
Essentially, yes.
Yeah.
It has lower lipid solubility than bupivacaine. This seems to be the key. It means it doesn't bind quite as avidly or persistently to those cardiac sodium channels. So, less cardiotoxic. Does the lower lipid solubility also improve the differential block?
It seems to enhance it. Because it's less lipophilic, it arguably has an even harder time penetrating the thick myelin sheath of the large motor fibers compared to bupivacaine. This potentially gives you an even wider separation between the dose needed for good sensory block, pain relief, and the dose that causes unwanted motor block.
Making it potentially even better for things like epidurals for labor or post-op pain where you want mobility.
Precisely. Many anesthetists now prefer ropivacaine for continuous infusions because of this combination of long duration, effective differential block, and improved cardiovascular safety margin compared to bupivacaine.
Okay, let's touch on a couple of specialized topical agents. EMLA cream, it's not just lidocaine in a cream, is it?
No, EMLA is clever chemistry. It stands for eutectic mixture of local anesthetics. It's a 5% cream containing equal parts of lidocaine base and prilocaine base.
Eutectic, what does that mean?
A eutectic mixture is one where mixing two solids lowers their combined melting point below the melting point of either component alone. In this case, mixing solid lidocaine and prilocaine creates an oil at room temperature.
Why is making an oil important?
Because this oil allows for a very high concentration of the unionized base forms of the LAs to be suspended in the cream. Remember, it's the unionized form that penetrates skin. This unique formulation is essentially the only preparation that can effectively anesthetize intact skin. Normal skin is a very tough barrier.
So you use it for things like starting IVs in kids or before minor skin procedures.
Exactly. You apply it under an occlusive dressing like plastic wrap for about 45 to 60 minutes, sometimes longer, to allow enough drug to penetrate the stratum corneum and numb the superficial nerve endings.
Interesting. And the other specialized one, oxethizane, for stomach issues.
Oxethizane is unusual. It's an LA that remains largely unionized even at very low pH. Most LAs would become almost entirely ionized and ineffective in the highly acidic environment of the stomach, pH 1 to 2.
But oxethizane stays in its membrane-penetrating form.
Largely, yes. This allows it to be formulated in antacid suspensions. When swallowed, it can exert a topical anesthetic effect directly on the irritated gastric mucosa, providing temporary relief from the pain of gastritis or severe heartburn. It's quite a niche application.
Okay, we've got the drugs. We understand how they work at the molecular level. Now let's look at how clinicians actually use them, the various techniques to deliver the LA to the target nerves.
Right, the application methods. We can start with the simplest. 1, surface anesthesia or topical application.
Just applying it directly onto a surface.
Exactly. Onto mucous membranes, eye, nose, throat, urethra, or sometimes onto broken or abraded skin. It only numbs the very superficial layers, the nerve endings there. No motor block.
We mentioned examples, eye drops like proparacaine, lidocaine throat spray, benzocaine lozenges, EMLA for skin. What's the main risk here?
Absorption. Mucous membranes are highly vascular. Soluble LAs can be absorbed very rapidly, especially from the airway. Spraying something like tetracaine into the pharynx or trachea can lead to systemic blood levels almost as high as giving it intravenously.
So potentially rapid systemic toxicity if you're not careful with the dose and agent.
Definitely. Caution is needed.
Moving on to injections. The most basic is 2, infiltration anesthesia.
This is simply injecting a dilute LA solution directly into the tissues you want to numb, usually just under the skin or into subcutaneous layers. It bathes the local nerve endings.
Used for?
Minor superficial procedures, stitching a small cut, removing a small skin lesion. Onset is almost immediate, but the duration isn't usually very long, and you often need quite a large volume of dilute drug to cover even a small area.
Okay, then we get into the more targeted techniques. 3, conduction block. This blocks the nerve before it reaches the area you're working on.
Right, intercepting the signal upstream. We can divide this into 2 main types. First is field block.
Field block. Sounds like you're creating a barrier.
That's a good way to think of it. You inject the LA subcutaneously in lines that essentially encircle the surgical field. You're blocking all the small nerves entering that area from the periphery. Think of numbing the abdominal wall for a hernia repair this way. You can block a larger area with less total drug compared to infiltration.
And the other type of conduction block is nerve block itself.
This is where you need precise anatomical knowledge. You inject the LA directly around a specific nerve trunk or a nerve plexus, like the brachial plexus for arm surgery or the sciatic nerve for leg surgery.
Much more targeted.
Very targeted. You can anesthetize a huge area, like an entire limb, with a relatively small volume of concentrated LA. And because you're blocking the main nerve trunk, which carries motor fibers too, you almost always get muscle paralysis along with the sensory block.
How quickly does it work?
It depends. Blocking small nerves might be quick. But for a large plexus block, like the brachial plexus, the LA has to diffuse through tissue layers and the nerve sheath, so it might take 10-15 minutes, sometimes longer, for the full effect to develop.
Okay, moving deeper into the body now towards the spine. 4, spinal anesthesia, also called subarachnoid block.
Here we're injecting the LA directly into the cerebrospinal fluid, CSF, that surrounds the spinal cord and nerve roots. The injection is usually done in the lower back, below the level where the spinal cord itself ends, typically below L2, to avoid injuring the cord.
So you're aiming for the nerve roots bathing in the CSF.
Exactly. The nerve roots of the cauda equina are the primary target.
How do you control how high up the body the block goes? You don't want it reaching the breathing muscles.
Control is crucial. It depends on several factors. The volume of LA injected, how fast it's injected, the patient's position, sitting versus lying, tilted head up or down, and very importantly, the specific gravity or baricity of the LA solution compared to CSF.
Hyperbaric, isobaric, what is that?
Hyperbaric solutions are made heavier than CSF, usually by adding dextrose. They tend to sink or travel downhill in the CSF depending on patient position. Isobaric solutions have the same density as CSF and tend to stay put near the injection level. By choosing the right solution and positioning the patient, the anesthetist can guide the block to the desired level.
And we see that differential sensitivity again here, don't we?
Yes,
Yeah.
very clearly. The sympathetic nerves are blocked highest. The level of sympathetic blockade is typically about 2 spinal segments higher than the level of sensory blockade, loss of pinprick sensation, and the motor block level is usually about 2 segments lower than the sensory level.
What are the main risks or complications with spinal?
The most common immediate issue is hypotension, a drop in blood pressure. This happens because the sympathetic block causes widespread vasodilation, blood pools in the legs, and less returns to the heart. It's managed by fluids and vasopressor drugs.
What about more serious issues?
Respiratory paralysis is a feared but rare complication, usually if the block unexpectedly goes extremely high or if severe hypotension compromises blood flow to the brainstem. A postdural puncture headache caused by CSF leaking through the needle hole is a fairly common but usually temporary side effect. Very rarely, persistent neurological problems like cauda equina syndrome, loss of bladder bowel control, can occur, sometimes linked to high doses or toxic contaminants.
Okay, similar but different is 5. Epidural anesthesia. Where does the needle go here?
For an epidural, the injection is made into the epidural space. This is the potential space outside the dura mater, the tough outer membrane surrounding the spinal cord and CSF, lying between the dura and the vertebral canal wall. It contains fat, connective tissue, and blood vessels.
So the drug isn't directly in the CSF.
No. It has to diffuse across the dura and arachnoid mater to reach the nerve roots in the subarachnoid space, and it also acts on nerve roots as they traverse the epidural space itself.
Can you target different levels with epidurals too?
Yes, epidurals can be placed at different levels, thoracic, lumbar, or caudal, at the very base of the spine, depending on the area needing anesthesia. Lumbar epidurals are extremely common.
And the big advantage, particularly for lumbar epidurals, is that ability for differential block.
That's the key clinical strength, especially with dilute solutions of drugs like bupivacaine or ropivacaine, for example, 0.1% or 0.2%. Because the drug has to diffuse through the epidural fat and across the dura, the concentration reaching the large motor fibers is lower than that reaching the sensory fibers.
Allowing pain relief without paralysis.
Exactly. Profound analgesia with minimal motor block. That's why it's so valuable for labor pain. The mother gets relief but can still move and push, and for postoperative pain control, allowing early mobilization. You can often leave a catheter in the epidural space for continuous infusion or top-ups.
Last technique. 6. Intravenous regional anesthesia, or Beer's block. Sounds counterintuitive, injecting LA into a vein for a regional block.
It does, but it works. It's mainly used for short procedures on the arm or hand, typically less than an hour. First, you exsanguinate the limb, squeeze the blood out, usually with a bandage. Then you inflate a pneumatic tourniquet high up on the limb, like a blood pressure cuff, to stop all blood flow in or out.
Okay, limb isolated. Then what?
Then you inject a relatively large volume of dilute, LA, usually lidocaine, never bupivacaine, into a vein in the back of the hand or forearm.
And the LA goes where?
With the circulation stopped by the tourniquet, the LA fills the venous system of the limb and then diffuses outwards from the veins into the surrounding tissues, reaching the nerve endings and small nerve trunks. Anesthesia develops within a few minutes.
The tourniquet seems absolutely critical here.
It is the linchpin of safety. It must stay inflated for a minimum period, usually at least 15-20 minutes, even if the surgery finishes earlier, to allow the LA to bind to tissues and prevent a sudden toxic bolus release when the tourniquet is deflated. And it shouldn't stay up for too long either, usually max 60-90 minutes.
And the warning about bupivacaine.
An absolute contraindication for Beer's block. Given its high cardiotoxicity, the potential consequences of accidental tourniquet failure and release of a large dose of bupivacaine into the systemic circulation are just too severe. Lidocaine is the standard agent. #tag outro.
Wow. Okay, that was a truly comprehensive journey.
Yeah.
We've gone from the chemical structure, the amphiphilic nature, the ester versus amide bonds, right through the molecular dance at the sodium channel.
Understanding how pKk dictates onset, how frequency dependence targets active nerves.
To the systemic effects, the crucial differences in toxicity, especially with bupivacaine, and finally, the sophisticated clinical techniques like epidurals providing that amazing differential block, and even Beer's block. It feels like we've really covered the spectrum needed for mastery.
I think the core takeaway, the real challenge pharmacologically, is that constant tightrope walk. You need the drug design to get into the nerve efficiently that requires the right lipophilicity, the unionized form penetrating. But at the same time, you have to minimize the harm it does if it escapes into the system, which is all about controlling absorption, understanding metabolism rates, the ester-amide divide, protein binding, maximizing local efficacy while minimizing systemic risk. That's the game.
It really is. And that leads us to a final thought, something for you, the listener, to chew on. We talked about that differential blockade, how drugs like bupivacaine and especially ropivacaine can selectively block pain fibers more than motor fibers.
Exploiting those subtle differences in fiber size, myelination, and firing frequency.
Exactly. It's not just convenient clinically, it's a remarkable achievement in targeted pharmacology. So the question is, what does this success tell us about the future? If we can fine-tune drugs to hit specific nerve subtypes based on their physiology, could we develop even more precise agents? Perhaps drugs that only target pathologically overactive nerves, leaving normal sensation and function completely untouched. Could this principle extend beyond pain to other neurological conditions?
That's the frontier, isn't it? Hyper-targeted neuropharmacology based on functional state, not just anatomy. A truly fascinating direction to think about.
Indeed. We hope this deep dive has left you feeling not just informed, but genuinely equipped with a deeper understanding of local anesthetics. Thanks for joining us.